Hello, I'm Gordon Caldwell. I'm doing something I've never done before. On Tuesday the 12th of May 2015 I'm going up to Wigan Hospital to give a talk, and later in the month I'm going to Ottawa Hospital. Now I've put together my PowerPoint and I'm going to talk through it as a rehearsal, so if you're interested, stick with me. However, if you happen to be from Wigan or Ottawa, please stop looking now, because there's not much point in me coming up to Wigan and going all the way to Ottawa if you've seen what I've got to say already. So I hope you've switched off, and for the rest of you this is just a rehearsal, so things are going to go through in an ordinary way. If I hesitate, deviate or repeat myself, please put up with it, and the stories I think are worth listening to. I'm going to give a talk on the ordinary importance of ward rounds. It's not a talk on checklists. Umesh Prabhu, the medical director at Wigan, asked me to come and do a talk on checklists, and being a bit radical and offbeat, I decided not to do that. There's my email address at the bottom, gordon.caldwell@wsht.nhs.uk, and if any of you find any of this interesting, please email me and we can correspond about it. Now, there's a picture of Umesh Prabhu, the medical director at Wigan. He's a paediatrician by background, and he usually starts his talks with personal accounts of disasters that have deeply affected him in his career. And the point of that, I think, is to show that we as consultants must always be humble about the role we play in patient care, how easy it is to get things wrong and for disastrous consequences to arise for our patients. He also tells these stories because we as human beings all love stories and remember stories far more than statistics and facts. So I'll start my talk with 3 stories. I'll tell you why I've told them later on. This is a picture of the left forearm of a gentleman who I treated for quite a severe community-acquired pneumonia, probably about 8 years ago now. He was a bit slow to make progress, but when it came to the day to discharge him from hospital, he asked about this painful area on his left forearm. So we looked and found that there's a small abscess there, and when the culture was sent off, this proved to be an MRSA infection, and he had an MRSA septicemia. Now this has arisen because we'd given antibiotics for quite a prolonged period of time. The cannula had been left in longer than it should have been for the antibiotics, and then when the antibiotics finished, it looks as if the cannula had been left in perhaps 24 or 48 hours after that, during which time this infection developed. So this man then spent another 4 weeks in hospital having his MRSA septicemia treated. Story 2. This is again a man in his late 70s, living alone, fairly fit. His daughter lived nearby, and she was concerned that he'd become unwell over the Christmas period, and in particular that he'd developed a swollen leg, and she brought him up to casualty because he wasn't well. In casualty, she told the nurses that she was concerned about his swollen leg, and although she was a layperson, was worried that he'd developed a deep venous thrombosis. He was clerked by the A&E SHO and then later by the acute medical unit junior doctor, and on New Year's Day his case was presented to a respiratory consultant who made a diagnosis of community-acquired pneumonia. His X-ray wasn't quite as dramatic as the one shown on the left there. 2 days later, which I think was a Monday, the respiratory consultant reviewed his case again, and he was making slow progress, and the consultant was content with the diagnosis. I then became involved in his care because he moved from the acute medical unit up to our ward, and as I remember, we did 2 ward rounds involving his care and agreed with the diagnosis of community-acquired pneumonia and that he was making rather slow progress. One evening he suddenly collapsed, and that night the registrar on duty was the respiratory registrar, who was concerned that the patient might have sustained a pulmonary embolism and arranged a CT pulmonary angiogram. The CT pulmonary angiogram confirmed that he had a pulmonary embolism, very similar to the CTPA shown on the right there. Unfortunately, shortly after the CTPA had been performed, the patient collapsed and died. The third story, much more recently, you may recognise this as Emma Thompson. She played a role in a film called Wit, where she is a professor of philosophy who had developed pelvic malignancy, ovarian cancer. This story is about a middle-aged patient under my care recently, and the first time I saw the patient I was very concerned about the history of metastatic cancer, and looking at the patient, my suspicion was that the patient was dying, had come to the terminal phase of the illness. However, the oncologist was very upbeat and wanted to continue with palliative chemotherapy if we could get over an episode of acute kidney injury with the EGFR down to about 20. We rehydrated the patient, dealt with healthcare associated pneumonia, and requested ultrasound of the kidneys, which showed obstruction of both ureters by malignant deposits. This all took a considerable length of time, probably 3 or 4 weeks, and eventually when the oncologist was away on holiday, her kidney function deteriorated again, and after consultation with the consultant on his mobile phone, we agreed that the urologist should proceed with bilateral ureteric stents under a general anaesthetic. This was done, and the patient was a little bit overweight and post-operatively developed quite a severe healthcare-acquired pneumonia on a Friday and died over the weekend. I tell you that story really because going back to the first time that I saw the patient, my gut feeling and clinical hunch was the patient was dying, and I feel that as a medical profession we stole the last month of that person's life when the patient could have been at home enjoying family time rather than meddlesome interventions from us. Now, those 3 stories, the first one, the cannula, which was left in, showed that we should have removed the cannula. We should have had a process for checking for the cannula. We should have taken it out and saved the patient 4 weeks in hospital. The second patient, I'm sure in retrospect when I looked at the notes, there was only a minor area of pneumonia, and yet the patient was severely hypoxic, had no history of smoking, and the rational choice would have been to treat for both community-acquired pneumonia and pulmonary embolism from the outset, whereas in fact the patient only received VTE prophylaxis dose of fragmin. Over the Christmas and New Year period, when we're under so much pressure of time, I'm sure that the respiratory consultant was never shown how hypoxic the patient was, at the same time as being shown the chest x-ray, the white cell count and the CRP. Then when the patient moved up to our ward, as I recall, it was after New Year, we're under intense pressure to discharge patients. I think we had 27 patients to see on the ward round that day, and I just took that the respiratory consultant had made the right diagnosis, continued with that, and missed the diagnosis of pulmonary embolism. In the last case, it was really a question of whether we stood back and saw the overview and thought about the patient as a whole and what we as a medical profession might achieve and might not achieve, and a question of who was in charge of the patient between myself and the oncologist, and a sad end with the patient missing a month of time dying at home. Now, I tell all those stories because those 3 stories could have had different endings if we'd been well organised on our ward rounds, thorough, and had all the information we required for making high-risk decisions available right in front of us at the time we're doing the ward rounds. So the moral of those stories is, really as Sir William Osler said, physicians as a rule have less appreciation of the value of organisation than the members of other professions. I've been thinking recently that we as physicians and surgeons and consultants around the hospitals have been very like individual professional practitioners like plumbers and electricians, carpenters, who run their own little small businesses, self-employed. There isn't a big national plumbing service or national electrician service, or even one run by Marks and Spencers and Tesco's. Each professional can act in his own way. And that's how we've tended to do it as consultants. We do our own thing in a big organisation. And we don't organise our processes of care on a large scale so that we can make the best choices and treatment decisions and overall management plans for our patients. I've been thinking over the weekend that the way I learned ward rounds is very much as an automatic behaviour. It's like getting up in the morning. I wake up, go to the toilet, wash my hands, go downstairs, have breakfast, come back upstairs, have a shower, brush my teeth, get dressed, go out at the front door, walk to work. Quite often whilst thinking of something else. It's an automatic behaviour. And I think that's the way that I learned how to do ward rounds. They're an automatic behaviour. We just did them, and quite often I would be thinking of something else during a ward round. They weren't very active and organised. So ward rounds were very ordinary, like getting up in the morning is very ordinary. But there's a great danger in the ordinary and in the routine and the automatic, particularly if there are wrongs in the ordinary. And Sir Robert Francis found nearly 300 wrongs just in one hospital, and actually I'm sure there are far more wrongs than that in our hospitals. There may be much more simple solutions than dealing with all of the 300 wrongs, but there are many ordinary wrongs. And Sidney Dekker, writing about disasters in the transport industry, talks about how the ordinary and wrong soon becomes the ordinary and acceptable. So we drive our car with a bald tyre and we think one day we'll get it sorted out, and eventually all the tyres become rather bald and it's a wet day and it's cold and there's a bit of ice on the road, and the ordinary and wrong, which has become the ordinary and acceptable, results in disaster. So when I was preparing for this talk, I found an old PowerPoint from 2004 when we did an audit on a post-take ward round down in our acute medical unit. And here's the findings. The clerking was dated and signed and timed in only 7% of cases. Most often it was that the doctor hadn't put the time, they had signed it, but we didn't know who had signed it because the signature was illegible. Only 29% of the times was a nurse accompanying the post-take ward rounds, so that rich, deep conversations with the patient about diagnosis, treatment and prognosis, reassurance around discharge weren't heard by the nurses. The nurses couldn't participate and express their concerns and ask questions on behalf of the patient. At that stage, we were still using central notes rather than a temporary folder, and the clerking was filed in the central notes in just 10% of cases, meaning that in 90% of cases there was a risk of the notes being lost, filed out of place, getting into the wrong notes. And at that time, only 50% of the patients were on the emergency assessment unit at the time of the ward round. 50% were outliers. We have improved considerably on that since we developed the emergency floor, and it's actually now quite uncommon to have to go and see outliers. That was 11 years ago, and what progress have we made on those ordinary wrongs in the 11 years? Well, we're better at noting the time when the patient is seen. I've got into the routine now of signing the entry in the note and putting the time at the end of the clerking, at the end of the consultation as well. We suggested we had a 24-hour clerk as a doctor's clerk for filing, so that everything was in the right place by the time of the ward round. We've had no progress on that, but I think there's 1 or 2 million people unemployed in the country. A ward clerk would probably attract minimum wage, very cheap investment for a lot of improved safety. We suggested there should be a specific nursing post just for the post-take round, and there was temporary progress on that, but in recent months and years we've regressed. And we thought we should decide where the ECG should be kept, and sadly there's no progress on that, and every post-take ward round that I do there's a struggle and difficulty in finding where the ECG is. So that's been about ward rounds, but I think it's always a good idea to put talks like this into context, and let's start at the big context, the meaning of life, staying alive. Staying alive is probably the first objective in life, and it's worthwhile remembering that hospital medicine probably contributes very little to the staying alive of the whole population. What keeps people alive is good family around about them to nurture them when they're young, clean water, enough food, and these days we know we have more than enough food with an obesity pandemic, which we should perhaps actually regard as a success compared with the 1940s and 50s when there was a shortage of food. Hygienic waste disposal, clothing, a roof over our head, and at last the medical profession starts to come in with immunisations. And if you have all of those things, even an amateur at staying alive usually reaches the age of 80 these days. The meaning of life. I don't know what the meaning of life is. I used to be involved a bit in religion when I was a teenager, but it seems to me now as I get older that the meaning of life is something to do with the sense of belonging to communities, small as in our family and our friends, our workmates, and large communities, the society as a whole, the British Isles, our nation, caring for everybody inside our shores. Individual identity is really important. Everybody fights to make themselves slightly different from other people, create their own identity. Creativity is very important, whether it's making music, whether it's putting on our makeup, whether it's our clothes, building, making things, doing things. We all want to be creative. It seems to me we all want to be creative. And with the creativity comes some fulfillment and of course enjoyment. Now the work of the health service within that for the people who live inside our shores is to try and create an environment for disease-free living, prevent the preventable illnesses, and immunisation is really important there. And of course in recent years we've seen emphasis on primary prevention of ischemic heart disease, stopping smoking, reducing alcohol consumption. Treat acute illnesses so that patients with suppurative appendicitis have their appendectomy and don't die. Patients with pneumonia get their antibiotics and don't die. Support living with long-term conditions. This is a large part of what we do in hospitals, mainly in our outpatient departments, helping people to cope with and live with long-term conditions. Always, and perhaps near the top for hospital medicine and general practitioners, is the question of, is a point of alleviating suffering. And then a major success is for us to ensure the patients come to a calm end of life when they've finished living. Those are all summarised in our NHS Constitution. So within that, the work of the acute hospital, I think, is to treat diseases in our cohort of patients that can safely resume life outside hospital, anticipate end of life, and provide for calm dying, and become better at this every day. If all our acute hospitals closed down, there would probably only be a little blip in overall mortality in the country. And perhaps the most important role that we in hospitals have is to show that we care and that we're interested in our patients and want to make life better for them in some way. When that comes down to our team of doctors working on a ward round, then I think this is very practical what we're trying to do for our patients. We want to establish or make the right diagnoses, deliver the right treatments at the right time before the pace of the illness outpaces our working. In the right place, this is really important that we get the renal patient onto the renal ward, the gastrointestinal patient onto the gastrointestinal ward, the trauma patient onto the trauma ward. There's some suspicion that the mortality for being on the wrong ward is as much as 1 in 40, and that includes escalation wards. So if we open an escalation ward, don't staff it properly, don't form the team properly, 1 in 40 patients may die there only because we put them on an escalation ward. The right pace, we must never let the illnesses outpace our work, and so much in the NHS slows us down with bureaucracy, believing that filling in forms is better than doing the care. And for our patients, the right to no avoidable harm. When I was training, this used to be called iatrogenic harm. And all the time we must be learning to do this better next time. So there's the Medicare Constitution. Healthcare is a human right, and in particular, right to no avoidable harm. So why do ward rounds matter? Well, it's during a ward round that we try to work out, are we making our patients better? Are they making progress? Are there unexpected setbacks? Have we got the diagnosis right? If they are getting better, are they getting better because of us or despite us? Have we missed some of the diagnosis? Are we taking steps to avoid harm? Are we anticipating and providing for end of life, like in that third patient story I told you? This is high risk work, and it's open to a lot of erring. That's a picture of 4 climbers on the top of Ben Nevis in the middle of summer doing the Three Peaks Challenge, surrounded by mist. Being on the top of Ben Nevis surrounded by the mist is a dangerous thing to do, and if you err off the path, you're soon over a cliff face. One of the things I think as doctors we're very poor at is describing what the clinical care cycle is. For people who do improvement work, this is very similar to a plan, do, study, act cycle. So for our patients, we make diagnoses and comorbidities and list the comorbidities. This is a really difficult piece of work. It's not easy to make a diagnosis. We've got lots of decision support aids that help us to work out what the right treatment is when we've got the right diagnosis, but making the right diagnosis is really difficult, and we don't make that plain to our managers that we need the past medical history, we need the long-term conditions, the medications, we need 10 to 15 minutes quiet, undisturbed interviewing the patients, 10 minutes examining the patients, 10 to 15 minutes thinking about the condition before we move on to our treatment plans. We deliver the treatment plans, we monitor to see how the patient is getting better. If they have a severe asthma attack, we monitor the respiratory rate, the peak expiratory flow rate, the oxygen saturations, the pulse. And then on the ward round comes the review of progress. Is everything going to plan? Is the patient better? Are they heading to death? Are they stable? And we repeatedly go around that cycle day by day on our ward rounds. Of course, on intensive care it might be hour by hour that you go through these cycles. It's plan, do, study, act, refine, correct the erring. So how complex are ward rounds? There's a picture of Kim's game on the right. Can you remember all those items and which one's been taken away or which one's missing? Ward rounds and our patients are actually far more complex than that, because quite often somebody's put an opaque box on the tray, hidden 2 or 3 things underneath it, and you don't know which one's been taken away because you can't even see them. I'm thinking particularly of urinary catheters there. So on Sunday the 10th of May I looked at my list of inpatients. I had 18 cases at that time, and we pre-prepared discharge summaries with diagnoses and comorbidities. And of those, in those 18 cases, I had 158 diagnoses and comorbidities quoted on the draft summary. 13 of the 18 patients I classified as clinically frail, so frail that if a sudden catastrophe happened to them, they would die. CPR would be ineffective. So I challenge you, can you remember 158 items in 18 cases when you're heading off on your ward round? But do you take a list of those conditions with you to make sure that the patient with pneumonia, you remember they've got diabetes and can check their glucose levels? The patient with a deep vein thrombosis and pulmonary embolism has an acute kidney injury, and have you checked through that the renal function's improving? Ward rounds, hugely complex. So there's a nice picture of Claire Burlinson, who was my F1 back in 2009, and her lovely looking baby. In April 2009, as part of my way I trained my junior doctors, I let Claire lead the whole of the ward round, the pre-ward round briefing. She did every patient review. At the end of it, we asked her how it had gone, and she said, I felt supported, but I didn't know if I did it all. I'd just been at the International Forum on Quality and Safety in Berlin the week before, and I said, I don't think anybody's ever thought what is doing it all on a ward round before. And I'd committed to try to improve quality and safety on ward rounds at that meeting. So that was a Monday, and I asked Claire and Roselle to go away and come back on Wednesday and tell me what they thought doing it all was on a ward round, and I'd do the same. So we met on Wednesday and drew up our ideas, and by Friday we had our first considerative checklist for a ward round. So there you are, a checklist at last. What we decided amongst ourselves was the things that should happen for every patient, and to make sure that we did these things for every patient. And what we're actually describing then is a process. Our process now, it's evolved and changed many, many times over the intervening 5 or 6 years. Now we have a preparatory discussion where we look through the clinical notes, the results, the ECGs, and try and make sure that we are sure that we've got the right diagnosis, the right comorbidities, we've looked at incoming results, we've taken a report on any exceptions, we've thought the case through. I know some consultants just turn up at the bedside, as I used to, unprepared and ready for the juniors just to tell us what was going on. I'd say that failing to prepare is preparing to fail, and all sorts of problems arise if we haven't pre-discussed the patients before we get to the bedside. Then there's consultation. Our consultations generally consist of social introductions and then what I call a more professional introduction. So once we've introduced all the members of the team, it's Mrs. Smith, what we understand from the doctors downstairs is that you're being treated for pneumonia, COPD, type 2 diabetes, your kidney function's impaired, you've got a history of a previous heart attack and you're on treatment for cardiac failure, and that you've come into hospital but your husband's very unwell at home. We work through the consultation of the obvious clinical problems, look at the charts, the drug chart, the diabetes chart, if the patient's on intravenous fluids, check the fluid chart and fluid balance. Planning for the next stage, and then the active safety checking, record it all in good documentation, and communication within the team and with the patient. Those are the big headings that we use. Now remind you that minor failing can have major consequences. The minor is as important as the major. If you're a cardiac surgeon, you've put in an artificial aortic valve and done 3 coronary artery bypass grafts, and the cannula is left in, like in my first patient who gets an MRSA infection, that then settles on the artificial heart valve. The patient develops bacterial endocarditis, and we know the likely outcome would then be death. That's a picture of the Challenger disaster. So, some ordinary wrongs, routine maintenance, belief that small defects didn't matter, resulted in disaster. Major therapeutic procedures can be undone by minor factors. That's why we've involved this active safety checking. You might say this is the nurse's work to do this, but as you saw, 29% of the time we have a nurse with us, 71% of the time we don't. So with every patient, every round that I lead, are you in pain or discomfort? How are you doing with eating and drinking? And since we've asked that question, far fewer patients on drips. Any problem with the bladder or bowels, with constipation, diarrhea? Have you got a catheter in? Has somebody left a cannula in your arm? Have you got a central line in? Is it comfortable? Are your pressure areas intact? And do we need to change your DVT prophylaxis? Start it, stop it, change it. So you might be interested to know how long does all this take. And these are figures up to about February of this year, when I've done 361 post-take rounds, 3,377 patient reviews, 15 minutes per patient for the whole thing, from the preparatory discussion to the end of the round. Nurse at the bedside, 66%, and falling well below that now since we opened our emergency floor, where the geography is difficult and it's hard for us to see the nurses to involve them in the rounds. Routine rounds, 443 rounds, 7,127 patient reviews, 11.7 minutes per patient, and a nurse at the bedside, 45% falling. It's fallen well below that. It's now around about 25% on my general routine ward rounds. So back to checklists. Checklists are commonplace. Whenever we're dealing with complex situations, it's a common step to go back to a checklist to make sure that we've done it all. So planning a meal, 3-course meal for your friends on a Saturday evening, highly complex activity, requires a shopping list to make sure that you get all the things you need. There's Bill Gates's Learjet checklist for flight safety, very short instructions about all the processes you have to go through to take off, to land, to deal with emergencies. And right in the middle there, a checklist modified from one of my own by Marius, one of your local surgeons here in Wigan, who developed one here that you could use without any ticky boxes to get through the ward rounds. And where those have been used, foundation doctors find them extremely useful to know that they've at least made decisions on all the important things. They sometimes have made the wrong decisions, but it's better than not making a decision at all. So checklists are commonplace. So I'll challenge you, how are you going to manage complexity? Now, the reason I've put up BMW and Lexus here is that my checklist won't work for your situation. Of course I like my checklist, it's my baby. I know it's too complex, I know it's too long, I know it's difficult to fill in, and all the problems with it. But the point here is, if you decide that it's a good idea to have a gearbox in a car, taking a gearbox out of a BMW and putting it into a Lexus won't work. The checklists, the processes, the way of managing your work has to depend on your local situation, what you see as important, what your team sees as important, and understanding the importance of checking it all and doing it all. So don't take my checklist and put it onto your ward rounds and expect it to work. You have to do all that hard work of deciding what's important, how you're going to check that everything's been done, and coming up with your own solutions. In Sunshine Hospital in Melbourne, in Grantham in Lincolnshire, the solution has been to develop a daily format or template for the ward round documentation. So keeping the clinical notes and doing the checklist are simultaneous. In Melbourne, what they found the most important factor here was that at induction, the registrars told the junior doctors, this is the way we work, this is the way you do it. When the consultants asked them to do it, it didn't work. When their peers asked, it did. So that's pretty much what I want to say about checklists, but I've learned a lot more in those 11 years since I started working on ward rounds, so here's a few top tips for rounds. Top tip number 1, know the who of your patient. Remember that I said hospitals are there to show that we in society care for each other. A really important part of caring is knowing who the person is. Within 30 seconds, 60 seconds, I can ask a patient what their previous work was, or what their current work is, or what their outside interests are, make a connection, note that down in the ward round sheet, and use that each day for a basis of some semi-social conversation. Often this makes the whole episode of care rewarding. So here's just a reminder of 4 of my person patients, and of course they're perhaps the more dramatic ones apart from the 4th. We were treating a man with community-acquired pneumonia on our ward, and the juniors hadn't told me anything about him, so I asked him about his work and his background. He had been Alexander Fleming's lab assistant when penicillin was discovered and was being treated now with comoxiclav, a penicillin antibiotic. Moving to the top right there, we had a man with extremely complex health problems as an outlier on an orthopaedic ward, very high calcium level which proved to be caused by thyrotoxicosis. Later we found that he was pan-hypopituitary and that his thyrotoxicosis alternated seemingly at random with an underactive thyroid. He was in his mid to late 70s, and when I asked him what his work had been, he said, "No, I'm still at work. On my laptop here, I'm advising the Japanese on how to decontaminate their nuclear power station after the tsunami." Bottom left, this is the man who's in the next bed to the nuclear power expert. He was very unwell with COPD, blue, difficulty breathing. Again, nobody had told me anything about him, so it gave me something to do on the ward round and asked him about his career. He had been the cameraman on every James Bond film that had been made up to that time. Then, just from last Thursday, I had to go and see a lady who had come in on my take and be put onto an outlying ward, and check that she was all right. When I got there, she was in a miserable state with pelvic malignancies, I think fistulas between the bowel and the bladder, an ileal conduit and a catheter in place with the urine dripping around the catheter, a towel over her knees, just looking miserable and uncomfortable. And her notes were probably about 4 inches thick, and I'd been through them. I said, "Your notes are so thick, but I can't find anything about you. And what was your work?" And she said, "Oh, I didn't work. I was really lucky. I had a child late when I was about 40, and I enjoyed bringing her up so much." And I said, "What do you enjoy doing?" "I play the piano, I compose music." And we had a conversation about the fabulous film The Pianist and Vladimir Spielman and his beautiful music. And that made her smile. She believed that I cared in her. Knowing the person, probably the top tip I'd give any consultant, any junior, any doctor. It only takes 60 seconds, and note it down. Remember the individual things about your patients. Another lady had a major subarachnoid hemorrhage, sent down to our ward, probably to die, regained consciousness, quite immobile, depressed, her young family 11, 12 miles away. I saw on her bedside table a stack of CDs and asked her if she liked 70s music, and she did, and that's what was bringing her joy in hospital. So we had a conversation about an Eagles concert that I'd been to. This was a Friday, and she wished us all a good weekend at the end of the consultation and smiled for the first time in 3 or 4 weeks. Top tips for rounds: know your team. So if Kevin turns up on your ward round, you better know that he's been to university, he's got a first-class honours degree in classics before he went into medicine, and has got a little bit of a problem with knowing how to dress appropriately to reassure the elderly patients of Worthing. So don't just introduce him as your medical student, make sure you know everybody's names. I'm very poor at names, I often jot them down on my ward round list so that I can remember people's names when we get to the bedside. So Kate Granger, you probably know, a doctor who is dying of a pelvic malignancy, running a Twitter hashtag of "Hello, my name is." Doctors were very poor at reintroducing ourselves to patients. We're actually even worse at reintroducing ourselves to other members of staff, so that everybody knows who we are, what our role is. But at the bedside, we should be able to introduce every member of the team. Other tips for rounds: form your team. On my post-take round, I'm generally working with doctors I've never worked with before, may never work with again. So I get them to form the team, I ask them about who they are, I get them to sign in and commit to working as a team on the ward round, that they will interrupt, they will raise concerns, flatten the hierarchy, prepare the team for the work. One of the questions there: plan if emergency arises during the round. The SPR will attend the emergency. Anticipate problems. Get efficient. I find so much that's horribly inefficient and irritating and difficult and hard about working on the ward rounds. So I've published a paper called "Cut the Crap," which is a doctor's guide to lean philosophy. One of the things that we did to cut the crap was redesign our ward round trolleys so that the notes are in horizontal drawers, so that when the physiotherapist comes to get the notes, she doesn't have to barge in and push you to the side and destroy the whole ward round. You can simply pull drawer 10 out, take the notes away and go away. Has nice shelves and a high level top so that doctors can write on the notes on a hard surface and their writing has a chance of being legible. And as we're slowly computerizing, we can put a laptop on there so that the doctors can do the discharge summaries on the ward round without leaving the team. Count. Change moans into statistics. Atul Gawande's advice. Stop moaning, do something and count. So get efficient. Top tips: give and take feedback. Describe to your team the work that you want them to do, what your ideal ward round would be like. Tell them whether they're meeting those requirements. Be very factual. Your clinical diagnosis was excellent, I can't read your notes. Your clinical reasoning was excellent, I can't read the drug chart. Very simple, very pragmatic feedback. At the end of a busy night, 17 patients admitted, thank you for your work. I was asleep, you were up all night, you've cared for the patients very well, they're getting better, I only had to change 2 or 3 things in the diagnosis and management plan, you've done a good job. And then take feedback as well. I've invited my teams to give me verbal and written feedback, and the changes that have come in my ward rounds because of the feedback I've listened to from registrars, juniors, even medical students, has changed the way that I do my ward rounds and caused improvements. So what? Does all of this make any difference? Ward rounds are so complex, so difficult, that gathering evidence that being organised, being effective, being consistent, being thorough, being complete makes any difference is almost impossible to gather. Since we've done this, I haven't had a cannula site infection in patients under my care. Now, was that because of what we did, or was it because the Trust at the same time has introduced a new cannula policy, new cannula observation chart? Very difficult to say. I do know that over the 7 or 8 years we've probably removed over 300 or 400 cannulas that have been left in longer than were necessary. So it comes back really to this question of creativity, fulfillment, enjoyment and caring. So the last story is the lady who died. This isn't too long ago. That's not a picture of the actual lady. She was a lady who, as I remembered, liked reading and playing bridge, and had developed an obstructive cancer causing jaundice and had had a stent put in. She enjoyed our rounds and our thoroughness and knowing who everybody was, and she learned the name of every doctor on our team and the name of our medical students. So when we arrived at the bedside, she would say, "Good morning, Jamie, Darren, Kat and Dr. Caldwell." So we didn't need to introduce ourselves. And she asked after us and how we were. Particularly after a weekend, she'd ask what we'd been up to and had we been enjoying ourselves. And one night, when we're planning her palliative care and discharge home, she died. And the whole team felt then a sense of sadness but fulfillment. We'd known her. We'd connected with her. We'd cared for her. She had connected with us. She enjoyed us and our company, and had died really in quite a peaceful and calm way. And I think all our work, what it's most done, is to increase the proportion of our time on the ward rounds that we spend with our patients, talking with them, sharing with them, planning, explaining, reassuring. So Umesh wanted to talk about checklists. Checklist is just a small, important part of a complex, high-risk teamwork process. There's that aeroplane on the Hudson River. And the pilots and the co-pilots had to, within seconds, find the checklist for restarting one engine, restarting both engines, preparing to land on water, landing on water, evacuating the plane, checking everybody was out of the plane, and then getting everybody off the plane before it sank. They used their checklists. It was highly complex, but it was just a small part of safe flying, emergency landing. So I hope I've told you or got you to start to think that our work is important, not as important as public health, not as important as immunisations, vaccinations, but it's important because it shows that we care. And if we care, we'll take the care to be careful and thorough. Thank you.